Assalamu alaikum. Good morning, everyone. Thank you all very much for joining in our portfolio pathway webinar. We are really grateful for your time, and we are grateful for our presenters for giving up their time to share their experience in portfolio pathway application and help guiding our juniors in hopefully initiating and then eventually moving on to submitting their application to General Medical Council for a portfolio pathway process. This is the first of the series of portfolio pathway webinars that we are planning to deliver over the coming months. We hope to deliver 3 webinars, the first of which is happening today as an introduction to portfolio pathway application. I'm just waiting for colleagues to join in. Those of you who don't know me, I'm Dr. Mansoor Ahmed. I'm consultant pediatrician and pediatric gastro at University Hospital of Derby and Burton, NHS Foundation Trust. I'm co-president of UKIPPO, and I have been Caesar assessor previously at Royal College of Paediatrics and Child Health. Obviously, Caesar has now been replaced by portfolio pathway application. We have got a very interesting program over the next couple of hours or so, and we have got 2 very experienced presenters who will deliver their sessions. And I would request all of you to keep yourself mute all the times and let the presentation complete. You can obviously use the chat functionality to pose your questions without any problem. And we'll pick up your questions at the end of the presentation during the QA session. So the plan is to start off with Dr. Nabiha Asad, and she'll deliver her presentation over 30 to 40 minutes, and then we'll have enough time over the next 20 to 30 minutes to do the QA session. And this will be followed by Dr. Sadia Zishan to continue building on the introduction of portfolio pathway application for the next 40 minutes or so, and that will be followed by 20 minutes Q&A using the question that you pose in the chat function. So without further ado, I would like to invite Dr. Nabiha Asad to deliver the first session, which is titled as Understanding the Pediatric Portfolio Pathway, Eligibility and Curriculum Essentials. Dr. Nabiha Asad is a consultant pediatrician with special expertise in complex pediatric epilepsy, having completed a fellowship in this field. She's an honorary lecturer at the University of Manchester and is actively involved in medical education and professional development. Dr. Asad has a strong interest in supporting and guiding clinicians through the portfolio pathway applications and regularly mentors doctors navigating this route. Over to Dr. Nabiha Asad.
Thank you, Dr. Mansoor. Before I start, just checking, can you hear me, Dr. Mansoor?
Yep.
Thank you. So welcome, everyone. yes, as Dr. Mansoor just said, that this is a great opportunity for all of you to go through what we've experienced and ask us questions. You've got a lot of experience present at the moment within the faculty. Dr. Naseem, who's an experienced pediatrician, and Dr. Mansoor, obviously you've just heard, is a very experienced pediatrician, and Dr. Sadia. So we've all got a lot of experience on hand, and we'll try our best to answer all your questions and queries. My part of the presentation involves the objectives for this would be differences between a portfolio pathway and CSER. What's the eligibility criteria, and pediatric curriculum and syllabus, evidence distribution, mandatory requirements, and then we will go down a question and answer route. Obviously, if you've got questions, keep putting them either in a notebook on the side or in the chat box. My colleagues will try to look through the chat box, but I would like to go through the presentation first before answering any questions, just in the interest of time and everyone else. The overall presentation is very generic for pediatrics. I know there are some pediatric subspecialty people on this call. We will try and answer that towards the end. However, this will be very much generic to pediatrics. So what's the main difference between CSER and portfolio pathway? There is obviously a difference in the name, what's it called, but however, the applicants will no longer have to demonstrate the full equivalence to the CCT program. Under the new approach, evidence will need to show that the applicants have achieved knowledge, skill, and experience required for practicing as a consultant in the UK. This is the information I have taken from the GMC website. So the framework for evaluating the knowledge, skill, and experience reflects the higher level learning outcomes achieved by UK trainees in pediatrics or relevant pediatric subspecialties. So you can see that there is more structured approach here. You don't have to tally curriculum, tally the CCT equivalence program, but you have to follow the pediatric curriculum and match the HLLOs, which were previously called domains. This will get a little bit more clearer as we go along, and Dr. Sadia has got a wonderful presentation to go through those things as well in detail for you. Okay, so what's the difference? CSER was called CSER because it was a certificate of eligibility for specialist registration. What is specialist registration? It puts you on a specialist register in the GMC where you can work as a consultant pediatrician or whatever the subspecialty you choose. This was the original route. The new name now is Portfolio Pathway since 2023 November, I want to say. This is more streamlined version for CSER. It's replaced by the old CSER application process, and the outcome is the same. The end result is the same. However, the process seems to be a bit more structured. Royal College of Pediatrics has worked very tirelessly with GMC to create this structure to make it easier for yourselves. So in the old process where we called CSER, there was massive evidence upload. People had to load up to 800 to 1,000 pages. This was common. You had to map everything yourself to the entire UK curriculum, very paperwork heavy and repetitive. Hard to know if you were submitting the right type of evidence. Portfolio pathway is more structured. The college gives you clearer guidance. College now defines specific evidence types, less duplication of work. So you can give one evidence and it could cover 2 or 3 HLLOs, designed to reduce unnecessary paperwork. And there is a lot more emphasis on quality rather than quantity or sheer volume. We will go through this throughout the next couple of hours, but it's the quality of evidence that they really need from yourselves. Old CSER felt like you were writing a thesis. There was high level of rejection due to technical mapping issues. It was less transparent on what was enough evidence. Particularly for pediatrics, I have to say, or medicine-related specialties. Specialties which are more surgical, they had a lot more sort of clarity on the number of evidence they wanted or procedures they wanted to show, whereas in pediatrics, it's always quality over quantity. Portfolio pathway, better curriculum mapping tools, more defined capability areas, clearer signposting of what assessors are expecting of you. And we're going to go through Q&A, and we can talk about what assessors are expecting out of your application. So it's still time consuming, don't get me wrong, but it's easier to plan because requirements are clearer, okay? And it's the same destination. I think it's a smoother road compared to CSER. It's just a modernized CSER. There's not huge difference eventually when you're trying to show that you can work as a consultant pediatrician in UK. So you will still need to show the same level of quality of work that you had to present for CSER. It's better streamlining with the curriculum. So the eligibility and curriculum essentials are extremely important. Portfolio pathway is for doctors who join the GMC specialist register and whose specialist training, qualification, or experience is outside the training program. So obviously some of you have been trained abroad. Some of you are working here for a long time and you are out of the CCT pathway and you want to take this route. So this is for those who are not in training, basically. I don't like to use the word who are not in training, who are rather self-directed training, in self-directed training. Portfolio pathway certifies that the recipient has the knowledge, skill, and experience expected of a consultant in a relevant specialty or subspecialty in UK. So we've talked about this. You've got your training, qualification, experience in pediatrics, but either you've gained this outside of the CCT program, or it's partly. So we've got people who were partly into training, then they took time out of training and did their own self-directed training. It's for them. If you've trained outside UK or EEA, moved abroad, or taken a career break, and you may want to apply for specialist registration in a CCT specialty. Your CCT specialty is general pediatrics, but subspecialty, which will be non-CCT specialty that has got a sort of different curriculum requirements depending on your subspecialty. And you've got to go into GMC page and look for your specialty-specific guidance for your subspecialty. You will need to demonstrate that you have the knowledge, skill, and experience that is defined in the specialty-specific guidance on GMC website. The knowledge, skill, and experience is keyed to the higher level learning outcome, which is the HLLOs. You'll hear this word a lot, and I'm sure you already have heard it. This is the new word for the older word, domains. These outcomes are the same as as specified in the CCT RCPCH Progress Plus, including clinical capabilities and generic abilities expected of all consultants that start working in the UK. So remember that whatever evidence you are submitting, it should be consultant level evidence expectation. If you're writing, we're going to go through documentation of what is consultant level evidence. Portfolio pathway applicants are again assessed against the standards expected for the specialty they have applied in. And those standards, how will you find those standards? They're on your RCPCH Progress Plus, as well as specialty specific guidance within GMC document. Specialty standards are laid out in higher level learning outcomes of the CCT curriculum for that specialty. So that's where the mapping helps, because the CCT curriculum has already got the high level learning outcomes sort of attached with it. So you will be mapping to those HLLOs. Incorporating the generic professional capabilities into specialty curriculum will change the structure of the curriculum, so they're based around the HLLOs. So for some of you, you might know all of this very well, but I appreciate that some of you will not have much idea of what generic professional capabilities are and what the high-level learning outcome is. So don't worry about it. We're going to keep going through the details in the next couple of hours. What are the suitable job roles that support CSER evidence or portfolio pathway evidence? I would say you've got to be in senior job roles, because the evidence that you can provide in senior job roles, SAS doctors, tier 2 plus registrar or local consultant, is more, I think, more quality worthy experience, only because you are expected to show to the assessors, and Dr. Mansoor can talk about this later in Q&A, the assessor doesn't know you, and you're supposed to show to the assessor that you are working at consultant level. So jobs where you have the opportunity to show the senior-led thinking and decision-making. Throughout the day, if you're working in the post that I've talked about before, you will be doing lots and lots of work and sort of generating evidence without realizing that you're actually doing consultant-led thinking in your day-to-day practice. And that's what you need to sort of structure out and lay out for the assessor at the GMC and RCPCH. And hopefully you're very lucky, I have to say, that you've got groups like this, a platform where you've got support and an opportunity to ask Q&A. I have to be honest, I did not have this. So this is really wonderful. Make most of it. Evidence. GMC prefers your last 5-year evidence. So whatever the evidence you're choosing, be careful to provide evidence which is as new as possible, showing your senior-led thinking. Obviously, if you've done a master's, MPhil, PhD 20 years ago, 10 years ago, you have to add that to your evidence. And you can't bring that within 5 years, right? That is acceptable. Your MRCP exams or FCPS exams or whatever you've done prior to 5 years, that's fine. What we're talking about, the last 5-year evidence, is your clinical expertise and experience with senior-led thinking. So if you have done a lot 10 years ago, but for the last 3 years, you're not able to show that, then that's not right. You've got to find ways of showing senior-led thinking and evidence that we've just talked about, with showing your knowledge, skill, and experience within the last 5 years. So you submit the recent evidence to support your application in line with the specialty-specific guidance for your specialty. Evidence falling outside this period is unlikely to hold weight in your application when reviewed by the evaluators, unless accompanied by current evidence which demonstrates the maintenance. So you've maintained your competency in that, okay? So remember, these applications, they are viewed holistically and they're assessed on their own merit, depending on what the overall body of evidence is. The following approach is taken when they're assessing. A small amount of older evidence may support your application if it's highly relevant to your specialty. To be relevant, it must also be the primary evidence, although this depends. For example, I think, let's make this clear. Your degrees, your sort of writing, you've published in PubMed or Lancet, and that was more than 5 years ago, that's absolutely fine. But coming to older evidence from your clinical practice will carry much less value, and it's going to be much more impressive, or important rather, to show what you have done in the last 5 years. Where much of your primary evidence sits outside the standard evidence time frame set out by specialty-specific guidance, this will not demonstrate a robust application and will need to be supported by recent primary evidence. Okay. So all of you who are on this call, I'd like you to be very confident and comfortable with RCPCH pediatric curriculum. So please look into your curriculum. You should know the structure of your curriculum. The curriculum provides a framework for training, articulating the standards required to work as a consultant. And elements of the syllabus set out the scene for what makes a pediatrician at the specialty level, what defines as a general pediatrician or a subspecialist. So really, the curriculum and syllabus go hand in hand. And if you are embarking on this journey, do take some time out and try and read and understand what the RCPCH curriculum and syllabus is for a pediatrician. So the domains that are in line with good medical practice, this is generic for all portfolio pathway specialties, but we're obviously looking at pediatrics. So you've got to show evidence in professional values and behavior. How will you show your professional skills? By practical skills, communication and interpersonal skills, dealing with complexity and uncertainty, clinical skills, history taking, diagnosis and medical management, consent taken, humane intervention, prescribing medicines, using medical device safely, infection control and communicable diseases. How can you show your professional knowledge? Professional requirements, national legislative requirement, and the health services and healthcare system in the 4 countries in UK. They require you to show your professional knowledge. So those of you, for example, who've passed their MRCPCH, that ticks a box for professional knowledge. Obviously, we've got to do CPD. Those of you who are working in trust jobs, you will be doing regular CPD activities. That ticks a box for your professional knowledge. Capabilities in health promotion and illness prevention, capabilities in leadership and team working, capability in patient safety and quality improvement, capabilities in safeguarding vulnerable groups, capabilities in education and training, and research and scholarship. So these are what we like to say the domains of good medical practice. How will the curriculum outcomes be achieved? So as I said earlier, you're doing this in your daily lives. If you're working as pediatric registrar, SAS or locum consultant, or senior pediatric in a senior pediatric post, you're already doing that in acute settings, in community settings, whilst handovers are taking place, when you're in the ward rounds, if you're doing multidisciplinary meetings, audit, research, if you're involved in simulations, all of the ones that we've just talked about, you can actually demonstrate that learning. Overview of the pediatric curriculum. Now, this is a very important document, and as I cannot emphasize enough for you to understand your curriculum before you embark on collecting evidence. So they've used something called capabilities in practice. This means that the trainees will be assessed against the fundamental capabilities required of consultants in a working week. These are known as capabilities in practice. Capabilities include general skills, which all doctors need to have, as well as those needed to carry out the specific day-to-day tasks undertaken by a consultant physician. The knowledge, skills, and behaviors. Now, as a consultant, obviously, you are supposed to have the knowledge, skill, and experience from educational and medical side of things. But unfortunately, that stops, and there is a little bit more on top. So it's not just the knowledge, skill, and experience. There is day-to-day management that you have to show. You got to show insight about patient safety. How do you want to improve your department? How do you want to get yourself involved in governance activities? All what we just talked about with good medical practice framework. Okay, so whatever evidence you're collecting for this application, look at a broader picture. Exams do tick a box, but we need your application to shine. We need more than just the exams. So more than just the medical knowledge, there is a little bit more to show off there. Okay, so here comes the higher level learning outcomes. Excuse me. So this is where this was called domains previously. There are 11 for pediatrics, professional values, behavior. You're going to be showing evidence for communication, clinical procedures, patient management, health promotion and illness prevention, leadership and team working, patient safety, including safe prescribing, quality improvement, safeguarding vulnerable groups, education, training, research, and scholarship. So if you see, all these 11 HLLOs are very similar to the good medical practice we just talked about in the previous slide. So how you see that the GMC good medical practice is in line with RCPCH HLLOs, okay? And all these 11 domains or HLLOs is what you need to focus on to bring your evidence in. Dr. Sadia will go through how to collect evidence and what to collect evidence through in the next set of presentation. But keep this in mind that this is what you're trying to show to the assessors, to RCPCH as well as GMC. I've got this from the GMC specialty specific guidance. Those of you who've seen it would know this pie chart. It's very useful. It just gives you the amount of evidence expected in these HLLOs or domains. So if you look at this half of this pie chart here, they want you to produce evidence on communication, clinical procedures, and patient management. So half of your application involves this. The rest of it is in the quarters. So professional values and behavior, leadership and team working, education and training. So have that in mind. This is the amount of evidence you need for HLLO 1, 6, and 10. The rest of the quarter involves health promotion and illness prevention, patient safety, including safe prescribing, quality improvement, safeguarding vulnerable groups, research and scholarship. Okay. There are lots of questions that come around research and scholarship, and I think we all agree that not everyone does research. There are people who like academic side of things and do a lot of research, but because there is an HLLO there, which wants you to map with the GMP, you could use research in many ways to show your evidence. An audit or a QIP can also somehow sort of sit into research if it's presented in a way. Obviously, if you've got a paper that has been presented or you've actively worked or you are working in a research, that is absolutely fine and that's great. But not all will be doing research, and that question keeps coming up again and again. So not to worry about it, and we'll go through it in Q&A. So all of you who are applying for pediatrics, APLS, NLS, and level 3 safeguarding is mandatory. So you've all got to show this. And as a consultant, we all have to show this experience anyway. So please have a look at these 3 useful documents. The first one, Pediatric Specialty Specific Guidance, you get this document on the GMC website. Those of you who have heard me before, I always say this should be your book to refer to. This should be your Bible to go through the whole process of portfolio pathway. You need to go back and forth to this all the time. They keep updating this on the website, so I would say do not download it. But if you've downloaded and printed it, do keep checking it every few months because they keep updating it. And the day you submit your application, that's when it will be the most up-to-date one to that time of application submission. Pediatric curriculum and syllabus, like I said, please go and check on this. You must be very comfortable with the understanding of your curriculum and syllabus on the RCPCH website. When I was preparing my application, I just emailed GMC, but there is an online document as well of good medical practice. This is a really useful, helpful document for all who are planning to achieve a portfolio pathway. And the beauty of this whole process is that it is tiresome, it needs structure, it needs organization, but you will see at the end of this, you're not only an excellent clinician, but you are actually somebody who understands the GMC requirement of being a good doctor. And that's what is needed at consultant level, because I think overall, lots of my consultant colleagues will agree, consultant life is very different to a registrar life. And it's slightly a lonely life. So knowing these bits and bobs of what GMC expects keeps you well aware of the requirements working as a consultant in the UK. So do get this good medical practice document as well. I'll try and put the links to these documents in our chat group eventually, once I've done this presentation. And that's about it. Thank you. So I'll come out of my presentation, and yeah, that's great. We're half an hour into that. And I'll stop sharing. Thank you. Brilliant. Okay, so we've got, oh wow, we've got quite a good number of participants here today. Brilliant. So yeah, I'm open to questions. I'm happy to answer any questions. Dr. Mansoor, I'm not sure I can, I can hear you.
So thank you very much, Nadia, for amazing introduction and your presentation. Thank you.
Thank you.
So the first question here is that is EPOLS accepted as
That's a good.
pediatric life support, I guess?
Yeah, I think it's pediatric life support, and it is accepted in most trusts. So I'm assuming it should be. Would you agree, Dr. Mansoor?
Yeah,
Yeah,
I think it
EPAS should
should
be.
be. Yeah, whether it's APLS or EPOLS, both would be acceptable standards. Yeah,
That's
alongside NLS, obviously. Then the next question from Bilal is, can level 3 safeguarding from trust-based courses suffice, or do we actually need RCPCH safeguarding
no
course?
level 3 from your trust, as long as it says level 3 on that certificate, should be okay. And most of us, we end up doing it from the trust. Actually, you've got to do it every couple of years, so that should be fine. Yeah.
Yeah. Okay. There's a question regarding e-portfolio. I think it's on RCPCH e-portfolio website. It says e-portfolio still has domains. It doesn't say HLLOs.
Yeah, that's right. So e-portfolio, if it stays domains, it does not matter. HLLOs is what specialty specific guidance is using now. If you open a GMC specialty specific guidance, the word HLLO is being used. It doesn't matter what e-portfolio is using. The words are domains and HLLO, the words are different. However, if you drop down and look at what we've just talked about, they're exactly the same. So it shouldn't throw you off just because the name is domains in the portfolio.
Hi, Nabia. Can I add on? I think they need to check with the Royal College because since it is the portfolio pathway, since then the e-portfolio has also been updated and it is HLLO. It's not.
Is it? Yeah, there you go. You got the answer to that.
Yeah, yeah. So is it, what's it called? Is it Progress Plus curriculum?
Progress Plus curriculum, and it is converted to HLLOs now.
That's right. Yeah. Thank you very much. Muhammad Bilal Mazhar is asking, do we have a number of procedures and skills and evidence against each domain required on the curriculum? Who would like to answer this question?
I don't mind. So, Bilal, that's a very good question, and it will keep coming in again and again. For pediatrics, we don't have a number. Okay. So, for pediatrics, you got to show quality over quantity. It keeps saying throughout. So, procedures and skills, if you're looking at procedure and skill and you've put a cannula in, I'm just giving you an example, in a 10-year-old, I'm not sure if you want too many of those. Rather, you want to show that you've put an IO in a research situation. So you just have to see the quality over quantity. Although your cannula will have its importance, but what's the quality? You were in a research situation and you managed to put an IO or a femoral line. Those are the type of things that you have to think of. There is no number given by RCPCH. Dr. Mansoor, you're assessor there. Do you agree?
Yeah, absolutely. I mean, there used to be, wasn't it, several years ago, you have to have X number of CBDs and X number of DOPs and mini caxes and this and that. That has been binned several years ago. Now it's quality over quantity. Yeah, definitely, definitely. Right. So the next question is, which e-portfolio should we be filling? Oh,
Okay. I think there is no right or wrong to this one. I'll tell you my personal example, and then Dr. Sadia can perhaps share hers. I used the RCPCH Kaizen when I was doing it, only because I've been trained in the UK, so I didn't have any experience from abroad, and I was always using this initially when I was in training. I found it easy. I found the work-based assessments to be done easily, and people knew about the portfolio. It's not a must. You can receive your portfolio pathway. You can do the whole portfolio pathway application without an e-portfolio. I'm not sure, other than Kaizen, I know of anything else, but I'm sure somebody else amongst the faculty would be able to guide us if there is anything else. It is expensive, I know, I'm sorry. I don't like it.
I agree with Nabiha that there are two ways. Either you do your Kaizen or either you do it on paper. Even from Royal College, you can download the PDF version, Word version of all those documents. Like it is created by the Royal College, which is accepted. So if you don't want to pay for the Kaizen, then your DOPS, your CBDs, your safeguarding CBDs, leader CBDs, your handover assessment tool, everything is there is a paper version of that. You can fill it and then you have to scan it and upload it on your application. It's whatever you like. But I agree with Nabiha. I have used the Kaizen, and what I did was I was trying to at that time match with my trainees who were my trainee colleagues. And after every 6 months, I was asking my supervisor to write my report as well, which has helped me a lot to guide me through that. I need to step up now because there is at least someone, my supervisor is looking through that. If you have your supervisor, and most of the specialty doctors do have supervisors, I think that it's your own personal choice, whatever you like to go for.
Thank you. Very similar question from Mazhar. Can we use our RCPCH portfolio for recording our entries? So the answer is yes. Hina Hashmi, thank you for this amazing session. In terms of experience from our home country, is there a number of years mandatory needed at UK? So I guess they're asking if we have come from abroad and come to UK, do we have to necessarily spend a number of years of experience in UK before we can start our portfolio application?
I would let Dr. Sadia answer
Yeah,
that.
I think because I would say so because I have worked in Pakistan, so I can answer that question. I would say if you are able to fulfill all the curriculum requirements from Pakistan, I would say yes. But because I have been trained and I've done all my FCPS training and everything from Pakistan, and then compared to coming back here and worked here, there are few things which you might find tricky. So it depends, but it's not impossible. It is that then your people who are going to do your paperwork and your verifiers and your referees, they need to understand the structure and all of those things, and then they need to write your assessment as per our curriculum, which sometimes is tricky. So if people who are working in UK or Ireland and want to do add on their previous experience, I think it's a good idea to use like 3 or 4 years from Pakistan and at least 1 year from here so that you have someone who's writing the report as per this curriculum as well. It's slightly hard about the safeguarding, and few things are tricky to get from Pakistan.
Thank you very much, Sadia. And would you say that bulk of your evidence still has to be within the last 5 years?
Yes.
Yeah. Right. Sudeep Banerjee is asking how many QIs required?
Hi, Sudeep. Nice to see you on this call. Sudeep, there is no number of how many QIs is required. But again, it's quality over quantity. So if you have got, I know other specialties like surgery, obs and gynae, they do want a full cycle of QI that should be completed by one person. However, Royal College wants you to understand once you've done once, for example, I have done a QI, the A side of QI, and then the B side, that is to check the changes, is left. You can do A or B, but you should be able to show that a full cycle of QI is completed in some format. You can pick up someone else's audit and complete it. That's absolutely fine. Or you can complete your own audit, but you've got to make sure that you can demonstrate a change. Dr. Mansoor, would you say there is a number of QIs that we want? No, it's quality over quantity.
Good QI project, service evaluation, quality improvement, audit, or research or whatever. It has to be of good quality. Breaking it into different steps and showing that it was worth doing it, and what difference did it make? How did you make the changes, and did it help the outcome overall compared to your objective? I think that's the whole purpose of submitting the evidence. It's not just submitting the evidence, it's showing that the work you have done was worth it. Sarah Ford was quite appreciative of the presentation and discussion, so thank you, Sarah, very
Sorry,
much.
before we move to next question, can I
Yeah.
just clarify one thing? The completing an audit cycle is mandatory now for the portfolio pathway.
Yeah.
So
Okay.
yeah, so that is mandatory. There are a few things slightly different. So completing a QI project of and completing audit cycle is mandatory, and it should be within 5 years.
Thank you. So the question about starting the application, and that sounds like very relevant to our phase one of this webinar. When we are not ready to start the application, can we use Kaizen or RCPCH to collect the evidence? I think this is the same question coming in again and again. Where do we collect the evidence?
Yeah, I mean, you can use Kaizen whether you want to start the application or not. Kaizen is only a platform to record your work-based assessments, your reflections. And personally, I find it very helpful. I'm even using it now as a consultant, and we've got that CPD diary, which we use. It's not a must, like Dr. Sadia just said. You can use your own sort of download the thing and start working on it, or anywhere where you can have a structured way of keeping your evidence. If you're not ready, I would still say if you're thinking about it in the next couple of years, do start recording your evidence somewhere where you can access it at the time when you decide you want to start your application.
Yeah. Very interesting question from Hina. In terms of evidence, what can be considered a proof if we don't have previous logbooks or evidence of our clinic letters or management? Yeah, tricky question.
So Hina, just need to sort of see what are you trying to prove. So I'll tell you how this is. So this is a piece of paper or whatever the document is. It's going to GMC and RCPCH assessor. Let's say Dr. Mansoor receives this. He will have no idea who this person is. You may be the top candidate in university school in your trust. The person there has no idea. So the only way is that they're going to see what you're saying, how you're tallying it to the HLLOs. So if you send your clinic letter, that becomes a proof. If you send your ward round documentation, that becomes a proof. And that's not just one assessor. Your application is going to be seen by two separate assessors. So for you to do an application without giving these documents, your document is your proof. Okay. Unless you're thinking of something else, I'm not sure if I've answered your question. You've got to prove your documents match the HLLOs for the assessor to say yes. And I think Dr. Mansoor can tell you a little bit more. When the assessor sends you the application, they have seen each and every page and read each and every document that is attached to it. So I would say the proof is what you attach. That's the only proof. They will not know anything else.
Yeah, absolutely. I think there has to be an evidence or a proof of just saying that I've attended 20 um, pediatric teaching sessions in the last 6 months is not enough. You need to have some kind of evidence of having attended the teaching session. I've presented in 6 of the departmental meetings and 2 regional meetings without sharing the evidence would not count as having presented locally or regionally. There has to be some kind of proof.
Plus, the other thing is, I think that your verifier needs to sign that. So no one is going to sign if you're saying that, because they would like to see what evidence before they sign as your verifier.
Absolutely. Absolutely. I think with regards to verification and choosing the referees, etc., etc., we'll probably come to it in our next or
It is the next session.
other webinar.
It's the next session talk. Yeah.
Yeah, that's right. Yeah. But certainly collecting the evidence is what you should be doing right now, really. Okay, so the next question is regarding community. For community, what we need, if unable to get rotation, do we need to do we need to be part of research, or do we need a publication? How do we use ePortfolio? Just anonymous and PDF? Everything needs to be signed by a consultant from Pakistan. Need everything signed? My apologies, lots of questions. So it sounds like um, it's about verification of the evidence that you are trying to submit. And what about research, and what about community experience? How could we do that without actually going into the community post or going into having a proper research fellow post?
Okay. So the good thing about Portfolio Pathway is that it doesn't require you to go out of your job to show, to do another 6 months of neonatal, tertiary neonates, or 6 months of community pediatrics. However, if you're trying to become a community pediatrician, I think it will be very difficult for someone to prove the breadth of knowledge, skill, and experience without working in community. This is my personal experience or my personal opinion. How will you show the breadth of your knowledge, skill, and experience if you want to become a community pediatrician, but you're actually working in acute pediatrics? So if you look at that, you may have to take up a job in community pediatrics. If you want to be a general pediatrician, then you don't have to go out and do community experience, but you have to match your evidence with the HLLOs. And one of them would be, health promotion, let's say. So if you've attended something like a LAC clinic, or you've attended something like immunization clinics or development something, you can just add that to it. If you want to become a community pediatrician, you want to look at your syllabus, your curriculum, your expectation of a community pediatrician, for which you will need a community pediatric job. Am I right, Dr. Sadia?
Yes, you're right. And I would like to add on, if you want to do your portfolio pathway for community pediatrics, it is mandatory to work overseas. If you are only working in UK, you cannot apply for community pediatrics, which is slightly odd, but this is the case still.
Including all subspecialties.
Yes, all subspecialties.
Dr. Sadia, over the next 30 seconds, a little bit about having the evidence verified from abroad. That was the other question. How
Yes.
could we do that?
So evidence verified from abroad, it should match what we do here locally in UK. So for example, if you have your basically any CBDs or anything, certificates that not need to be verified, but if you're doing your case-based discussions, your DOPS, they can use the Royal College PDF and then get it signed from their supervisors there, and then that has to be verified as well. So it's almost the same thing, but it should be done locally. There, the document can be used from here.
Thank you. Dr. Farid, I think is from Ireland. They're using Kaizen in Ireland, but with RCPI. And they're hoping that they can use the same for the evidence as
That should be
evidence
fine.
of their collection. Yeah.
That should be fine, because if they can download it and attach it to because even Kaizen, because I'm one of the Royal College Southwest region representative, and I've been trying to push them that if someone is using Kaizen, our CPSS should be able to look at that rather than doubling, because what we do is we have to download everything and then attach it to our application, and then they see it. Similarly, if they are using that Kaizen, they can download it and attach it to the application. So it should be the same thing.
Yeah, thank you. Again, this comes back to the same point that it doesn't matter which portfolio system are you collecting the evidence, as long as you are mapping it against all the HLLOs, you should be okay.
And similar should be in Pakistan. If for the FCPS, I don't know what, because when I did Pakistan, it's years ago training, we didn't have that. So if they have any sort of that portfolio in Pakistan, they can use that as well.
Yeah. And don't necessarily understand this question very clearly, but it says which one should we be filling? And then they have a screenshot core level and specialty level. I think they're asking which bit of the portfolio should they be filling in for their portfolio pathway application.
Specialty level. You've got to be closer. Specialty level is above ST6. So although they say they don't match the CCT curriculum, but there is not, I'll be honest with you, there is not much of a difference. It's just more structured. You are expected of working at, not as a core level, at a higher level. So it's the specialty level.
Okay.
Yeah, if you have done if you are a Royal College member and you email the training services team that I would like to get the access for the portfolio because I'm planning to go for portfolio pathway, they'll give you the right access. So you don't have to worry about that.
And Dr. Sadia, can you once again please clarify about the audit and audit cycle? People are a little bit confused.
So for audit cycle, basically, you don't need to have like a certain number of audits to be done. It is not mandatory. But first thing is that your audits, all of them should be within last 5 years. The second thing is at least you have to complete one audit cycle, and that is what is going on recently. There are quite a few people who I am helping them with their Caesar application, portfolio application. Their application has come back just because I think quite a few of them will be in this meeting as well. I don't know whether Amna, are you here in the meeting? I'm just not sure. She can comment on those things because she's dealing with these things at the moment. So this is something which is going on.
Yeah.
So it's
so the other question is from Mazhar that he attended a workshop and the speaker mentioned that at least you should enter minimum of 150 files. Do you agree?
So not minimum, that is basically, I will talk about in my presentation, I'll talk about that. It's not minimum, it is up to that. If it is anything beyond that, it makes your number of, I'll show you how I have collated. So we'll talk about that in my next presentation.
So you're going towards a maximum rather
That is maximum.
maximum. Yeah, that's right. And RS is asking, do we need both core and specialty level evidence to be submitted?
No. Specialty level, definitely. Yeah. You need something that you got 150 uploads and you have to prove to them that you are a consultant.
Exactly. Yeah.
So that's, if you start putting core level evidence, you're actually losing your opportunity to show off your evidence. So please work on your higher consultant-led thinking evidence.
Okay, so last few questions, then we are hitting 1 hour mark almost. Mazhar is asking a very interesting question. How to start this process? Do we need to make an account with GMC for portfolio pathway?
That's a good question, Mazhar. And yes, if you want to start your application, you can start an application process on the GMC website. Remember that website becomes a portfolio as well. So you start uploading your evidence on that website. It's like an application. It's actually really nicely done, and it'll start showing you all your evidence that keeps going in to the domains. But remember, the caveat to that is that's only open for 18 months to 2 years. So if you start today and you will not be able to finish it in the next 4 years, then after 2 years they'll email you to say that it's been 2 years. What are you doing? And we might have to close your application. So then you can say, okay, please, can you extend it for a few more months? But I would suggest strongly, do start that application process when you're halfway through your application, because you don't want to be under that pressure. Once they close the application, you lose all your documents that are on it. That's not the case with the RCPCH portfolio. RCPCH portfolio is your portfolio. You keep it there. And you can keep uploading for years. So I've got it for like 7 years ago. What I have there, it's still there. Whereas not with the GMC application. So that is one thing to think about. And how do you start it? If that was your question, that is the way to do it. I think you've got to make that decision and start your commitment towards it, making sure that it is daunting. But like anything in life, if you have got a goal, although it's going to be hard, but there is a lot of support out there. A place like this, I'll be honest, I don't think this was available 2 years ago to anyone. So there are people out there to support you, help you, share their experiences with you. It's not impossible. It just needs the organization skill, family support, and your departmental support to find your support network.
Definitely. And also, I would say make a decision. And if you want to really do it, start. That's the first thing. And also set aside tiny bit of time, whether it's every day or whether it's a set amount of time every week, but you have to do it consistently. You can't just do it and then not do it for 3 months and then do a little bit and not do it. You have to do it consistently to collect and complete the evidence. Muhammad Bilal is asking, when we are writing Kaizen, can we only write details of the evidence and get it signed by a senior or colleague, or do we still need a documentation of note to attach with it?
I didn't quite understand that question, Dr. Mansoor. So they mean the evidence as a document to be attached, or can we just get it signed by a colleague without that document being there? Is that what that
I think it depends what evidence are you talking about, isn't it? Is it some kind of workplace-based assessment equivalent document, which obviously will be signed by somebody else who will be assessing you, or is it reflection or something else, isn't it? Sadia, do you have anything to say?
Yes, so in my next presentation, we are going to talk about all of that, that once you're using your portfolio Kaizen, for example, if you have done a case-based discussion and you have done that with your consultant and he signed that, that is enough. But how to make it more stronger on your portfolio as well, there is a place to attach the document. But for the GMC application as well, what you should do is to make it more stronger is that you can use your notes or documentation. For example, if it was a leader CBD, you have resuscitated someone and you have discussed that as a leader CBD, your documentation about all that resuscitation and any procedures you have done is going to be your second part. First is your case-based discussion. Second is that document which you have used. And third is at the end of your case-based discussion and attaching that document, you have written your reflection, what you have learned from this case, and how you're going to change your practice afterwards. This is going to make your evidence very strong. Just attaching a CBD is one thing, but how your application is more stronger, this is the way how you make it strong. So I'm going to talk about it in my next.
Yeah. Amna is asking quite a relevant question, I suppose. And she's sharing her experience of having submitted her application.
That's why I asked her if you're there.
And she has submitted DOPS of mandatory procedure. Now she's being asked to actually submit more DOPS. So she's a bit unsure about the quality and quantity. So can one of you elaborate about, for example, a DOPS, whether it's cannulation or intubation, having observed intubation, having done dependently and independently, and then maybe having observed or guided that same intubation to a junior, going to the next level, really. So that evidence of having to maybe submit more DOPS.
So mandatory training DOPS will be the 3 mandatory training we've talked about, right? They want APLS, NLS, and level 3 safeguarding. Then there is a DOPS in Kaizen, and I'm sorry for those who don't have Kaizen. I'm just talking from my experience, but there are ways to show your DOPS experience. So DOPS is basically the direct observed procedure skills. Now, again, we come to the same example. If you showing 3 cannulations, okay, it's great. The number of DOPS tick boxed. Okay, even let's say you've put a cannula in a 24-weeker. Okay, that does tick a box for your cannulation. Have you taught someone how to do it? Have you done UVC, UAC, long line? Those are the type of DOPS at consultant level that makes the assessor feel comfortable that you can be left as a day 1 consultant. Okay. Now you've shown that DOPS, just like how Dr. Mansoor Ahmed said, and then you've taught somebody, and then you've reflected on that. So we're not taught how to do reflections in our lives until you go through this process, and then you'll become a pro at reflecting. I know you will do it, and every day you will reflect, right? Reflection is what went not so right and what could be better and what could I do next time to make it even better. That's how your reflection will be. So you did a long line and you did wonderfully. Somebody was observing you. Next time you will teach someone, and how was that experience for you? There is no number. Again, if they have come back to you from RCPCH to say submit more DOPS, they want perhaps more quality. They will not say submit more DOPS for UAC or UVC, 3 more or 2 more. They will not. But they will probably want you to show higher level experience working as a consultant. Does that make sense?
Yeah, thank you. So the
Could we
last,
let Amna
Oh, she's got a hand
comment
raised.
on that? I think it's really important to clarify things.
yeah, yeah. So Amina, saying similarly for workplace-based assessments, I've been working as a locum consultant for 4 years in NHS. My WBA for other trainees is more than my own personal. I've been asked to provide more of my own evidence of
Yeah.
WBAs. To me, it sounds or feels more like they're still matching evidence to a trainee who is doing CCT rather than seeing evidence of an individual who is already working as a consultant.
Do you want me to answer that?
Please.
So currently, I am in the process of 4 pediatricians who are currently working as a locum consultant, and their application has come back, and I'm helping all 4 of them. And this is, I don't want everyone else to feel depressed about that this has come back, because still there is a bit of confusion about those things. Yes, I agree that all 4 of them, it's come back that because they were consultant and they were supervising more, they still are asking more and more DOPS, which looks quite awful. That why, as Nabia said, why would you like to put like 3 or 6 or 10 cannulations? What you should ideally do is DOPS, basically, even if you want to match it for the trainees, they would like to have the 4 mandatory DOPS. As one is that someone should observe once, but rest of them should go to the skill logs. And I've seen Amna's application, and she's done that. She's provided all of that. Still, they are asking more DOPS, which is slightly bit tricky. That shouldn't be the case. But ideally, I would say I still agree that once you have done DOPS and once you have shown that you're supervising others, and then you have got your skill logs where you have mentioned that this many number of procedures I've done, but you don't have to provide evidence and someone has signed that, should be enough.
Okay, thank you very much. I really apologize for skipping some of the questions as we are now entering into our second half of this webinar. And I would like to take this opportunity to introduce Dr. Sadia Zishan, who is a consultant pediatrician with a special interest in pediatric diabetes and endocrinology, having worked across general pediatrics, neonates, and pediatric diabetes at Dorset County Hospital. She successfully completed Caesar application through the portfolio pathway process, and she's committed to delivering high quality evidence-based care for children and young people. Alongside her clinical work, she has a strong interest in medical education, and she currently serves as a medical student and physician associates lead, SAS tutor, and RCPCH Southwest Regional Representative. Dr. Zishan is a she's passionate about fostering high standards of practice, supporting colleagues in their professional development, and guiding those progressing through training and portfolio pathway applications. Over to Dr. Zishan.
Thank you, Dr. Mansoor. So I would like to, can you see my slides?
I think, yeah, if you could just start from
Yes, so let me,
title page of your.
yes, so let me go back and Can you
Yeah,
see my
that's
slides now?
perfect.
Yes.
Perfect.
So as we have discussed about the curriculum, and there might be quite a few things of duplication because obviously the evidence is what is the curriculum. So I'm going to talk about that. I might skip few of my slides because they have been nicely covered by Nabiha. So I would like to leave some more time for the question answer sessions afterwards. So today we are basically going to talk about the tips and tricks how to collect the evidence and how to save and make sure that this is relevant. So basically agenda for our discussion today would be how to get started with the portfolio pathway question, which was curriculum, which was basically the one of the questions today. What evidence you need and how to collect it, how to organize your portfolio effectively, and I'll show you some practical examples of my own portfolio pathway application, and then we'll leave some time for the question answer sessions afterwards. So basically, getting started, as Nabiha has already discussed about, the first and most important thing is to read the specialty specific guidance. And honestly, I must tell you, whenever I read, even after submitting my application, I find something new in that. So I would suggest you to read it very thoroughly and then make your own summary of those so that you don't have to go through all those quite a few number of pages again and again. So read it thoroughly, make a short summary of it, and then keep it with you. And as Nabiha has mentioned, keep going back on the website and keep checking what they have updated. Then Nabiha has very nicely covered about the eligibility and all that stuff, so I'm not going to go in detail of that. I would really like to talk about identifying the gaps in your experience, because all of us are working really hard and working as senior level pediatricians, but we all need to find out what gaps we are facing in our self-directed learning, because we when we were in our specialty doctor jobs, we were not having those sort of availabilities like the trainees do have. So we have to identify those gaps ourselves, and then we have to find our ways how to cover those gaps. And as we were discussing earlier, that we have like now we have a platform where we can discuss all of this, and you have that support. So first of all, it's difficult for us to guide what gaps you have. You might know very well where are you lacking, and then you can get and seek support that how you can find some help to get that sorted out. Then how to plan the portfolio pathway timeline. This is a very important thing. I know quite a few people who have been talking to me for the last 7, 8 years that they want to do the portfolio pathway, which was called Caesar before, and have not yet started. So people keep talking about that, but they have never started. They keep saying it's a struggle of time, and I agree with that. Particularly people working in NHS, it's hard to find time, but then we can see there are few examples people have done it, so it's doable. The other thing is, I would say, we always hear negative comments about lots of people talking, but we rarely see people talking positive about that. And whenever we have got loads of WhatsApp groups about the portfolio pathway, and everyone is asking too many questions, and then quite a few of the negative answers have been given. I must say, always try to find the positive of that. Caesar is doable, and if you have a certain number of amount of time you keep it for it, it can be possible. So I'm going to talk about my experience once. I'm going to share my application documents, and then I'll tell you how I did that. The first and most important thing, again, Nabi has mentioned GMC guidance, and make a summary of that as well. You have to go through all HLLOs, and then you have to make sure that you have read all 11 of those, and you know that this is your gap and how you're going to work on that. So then I'm going to talk about how to make your evidence more effective afterwards. So basically, how to organize your portfolio effectively is, I'm going to stop sharing this slide and I'll show you, all of you, I must suggest that you should, as soon as first step is read the CSER specific guidance, Then go on the GMC website, check your eligibility criteria, read the guidance, make the summary of that. Once you've done that summary, the next step is to decide, do you want to do it on Kaizen or do you want to do it on paper? Once that step is gone, the next step is make folders on your desktop. You have 11 HLLOs, so you'll make 11 folders, and I'm going to show you how you do that. So I'm going to stop sharing this screen, and then, no, so I need to still share the screen, but I'm going to show you. Yeah, because that's down to all the people that put through that one. It was such a mess as well. I'm sorry, I'm just literally struggling to minimize the screens to show you my desktop. Never mind, let's carry on with this one and then I'll try to do it afterwards. So basically you can...
Sati, you will have to share the video if you want to show.
So can't you see my video at the moment?
No, you have to share the video first.
Okay. Let's finish this and then I can do it at the end because I have to show them every folder separately. So rather than me going in and out, we can do this first and then I'll show them. So then in those 11 HLLOs, you have to make the subfolders in each of the folder to put the things in the right place. And then you have to name them appropriately as well. If you don't name them appropriately, at the end of the time when you have those 11 folders, you will struggle to find where have you placed the things. So you have to make a proper name so that when you are going to go and find those folders, you know where your things are lying. You should make some small templates and spreadsheets where you keep those things, that at least you have got a spreadsheet as a separate where you have written. What I used to do was I had a red, amber, and green things. So any area where I'm lacking was red, where I had few evidence and the remaining was still left, that was amber, and the HLLOs which was completed has gone green. So it made me very clear sort of thing that, for example, out of 11, if my 4 are green, I know that my main focus when I'm working on my on call is on these things because the rest of those 4 were already green. So that color coding helped me in that sense. Then again, develop a habit of writing a reflection for everything, and then mapping your evidence as per your curriculum. So reflection writing, I must say, is something which is very important, particularly when you are going through, for example, if you are on call for 3 consecutive long days, you have seen few things on the ward. I would say, yes, you're tired at the end of your 3 long days, but what you should do is that you should think back once you have your nice rest, that in these 3 days, what are the things which I've done which can go into my portfolio pathway application. If you don't have time to write anything, write on a small Word document. For example, this patient, this patient, this patient, and this was the case. Just write it down with the date so that when you don't have the time at that time, later on, at least you have saved it on that Word folder. That's why I said make a spreadsheet. I had that spreadsheet and I used to write that I can go back and look through it when I'm not tired and I have enough time to sit and do that. Because then you can go. I don't know what different trusts, some of them do have it on their, like they will write on papers. Some of them have got everything electronic on the computer. So it depends on whether you have to collect the evidence from your medical records, then it's better that you do it as early as possible. Some trusts still have that on paper, but then eventually it goes on their electronic, it's scanned and it goes on their computers. So it depends how your trust is doing that. But if you have the patient's details and date, what happened, then at least you can go back and collect it. But I would rather not leave it for a long time, because if you leave it for a long time, then you forget the whole story. And I must say, write like 5 sentences at least about your reflection on that case, roughly, literally in your own simple language. Don't think about writing a proper reflection at that time. But when it actually happened, if you write a reflection at that time, no matter your English is not good, no matter it's not a proper reflective lines, but at least you have written a small description of that. And then later on, you can sit go back and write it properly. But at least what happened and what you learned from that is more than enough to document on your Word document and then enter it on your spreadsheet, and then you can use it afterwards. So basically, total number should not be more than 150 documents. I'm talking about documents. Sorry, it's written pages, it is documents. So difference between document and pages is when I was talking about my folders, in 11 folders, you have to divide it into subfolders, and in every folder, every folder is actually a document. So for example, if you have CBDs, all your CBDs for your management HLLO is going to go in that folder. So your CBDs are all together, and that is one document. Your DOPs are going to be, for example, your mandatory DOPs can be your one document. So one document can have number of pages. So if you have 10 CBDs, 5 CBDs, they all can be joined together and become one document. So your one document can have more pages. So no, your document should not be more than 150. They still say up to 800 to 1200 pages, but I must tell you that as much as you are going to submit more, there are more likely chances that you're going to go in trouble more. So as far as you are confident that you have provided a good, practical, and quality evidence, then you should not be worrying about number of pages at all. So I would say even don't count it if you think it is less than 800, less than 1200. So, and your evidence should be balanced across all HLLOs, and the balance should be across all 5 years. I have been mentoring quite a few people for their application, and I've seen their evidence is quite bottom heavy, like last 6 months, last 1 year, everything they have done now. And the first 4 years, they are only showing me the CPD certificates and tiny bit of few things. Rest of the evidence is in last 1 year, and that is not acceptable. So you have to show your evidence for the last 5 years. So I must say, if you are deciding today that you are going to submit your evidence, you're going to go for your CSER application, ideally you should minimum at least next 2 or 3 years you should aim. You can collect the last 2 or 3 years evidence now and then go for next 2 years, rather than now you're deciding that I'm going to go for my portfolio pathway application and aim for next 1 year. That is going to make you into trouble. One thing is it's going to stress you out. The second thing is that you might not be able to provide a good evidence because you're going to rush. So take your time, be slow, but eventually that's going to help you collect the right evidence. And honestly, I would say it's not the only matter of the evidence. Even your application gets approved, if you have not gone through this proper pathway, you're not going to be that clinically sound pediatrician, because this is something which is done for a reason. They want us to provide this evidence for a reason. And I don't want you to be in a trouble because you have rushed and gone through your application and eventually you are struggling because you don't know the basics of lots of things in NHS. Again, Nabia has talked through all of this evidence, so I'm going to break it down. Basically, again, that if your second, third, and fourth HLLO, second is your procedures, third is your communication, and fourth is your patient management. This is the main bulk of your evidence, and it is basically 50%, which means if we are talking about 150 documents, then you maximum 25 documents per HLLO you should be providing. And then for the first, sixth, and 10th, first is your professional values and behavior, sixth is your leadership, and 10th is, I think, your education and training, I believe. And that is again 25%, which means at least 12 documents per HLLO. Then remaining your health promotion, patient safety, safeguarding, and all those research, they are again 25%, which means 7 to 8 documents per HLLO. And I'm going to talk about all of this in my next session. Basically, I just want you to have a rough idea because this is for the people who are just starting. My next session is going to be for the people who have already collected 50% of their evidence. So I'm going to talk in detail in my next session about all of this. So let's talk about all the HLLOs one by one. So professional values and behavior, as we all know, is something which they need at least, it is one of the, again, main bulk. So 2, 3, and 4 is 50%. 1, 6, and 10 is remaining 25% to at least 12 documents. It is not difficult to go through this one because mainly you need to have your last 5 years appraisal, minimum of 3 appraisals, they say. But still, again, I've seen that people who have submitted 3 appraisals and their application has gone, they have come back and asked, can you send us all the 5 appraisals? So there is no harm to upload all of your last 5 years appraisal. And obviously, if you're submitting your application for the last 5 years, you do have your revalidation, at least one revalidation in those last 5 years. So you can make one document which includes all your 5 years appraisal along with your revalidation. So that will be your document 1. Then reflection, I must say that on all HLLOs, one document is mandatory, is reflective notes. It should be in all of your HLLOs. So you need to write reflection on professional values and behavior. If you read your curriculum properly, you will know what sort of things come under professional values and behavior, and you can write reflection on those. Then again, there are few like ethical reasoning and consent examples. You can use those as well. If there are any datics you have been involved, you need to write reflection. And then it's not that you have submitted a datics and that's all. That is a junior level of reflection. You need to provide the evidence that you're working as a consultant level. So any datics you've done, and then after that, you have to demonstrate any changes done after that datics. Even those changes worked or not, that doesn't matter, but what you decided and how you have worked on that. And then again, quite a few examples of professionalism in challenging clinical situations. And I must say, if people have gone through the Royal College website properly, if you read that thoroughly, they have given a hell lot of examples along with small scenarios, and they have written some reflections on that as well. You can use it as your baseline, read those. And then if you come across such situations on your own calls, then sit down, write your own reflection, go back, read what is on the Royal College website, and then tally whether you need to do any changes and then make it properly. Then the CPDs are all which in your last 5 years, and it's easy to do. You sit on your appraisal and see in the last 5 years what you have submitted on your appraisal. All those CPDs are going to be included in this first HLLO. Then your second one, this is the main bulk. So communication is a must thing in pediatrics, as it's must for all the specialties, but in pediatrics, because you're dealing not only with the child, you're dealing with 2 parents as well. So I must say that communication is something which is very important, and they want to look at not only our verbal communication, they want our written communication as well. That's why clinical letters are something which they will look at our written communication. So if you have your clinic letters and you're doing your clinics, you should provide some good evidence. And I must say, if you have decided today that you want to go for your portfolio pathway, from today onwards, when you're sitting in your clinic, you are seeing a patient and you have read your specialty guidelines, then you know, for example, if you're seeing a patient with constipation, what sort of things are going to tick box in your curriculum, which can help. So aim that this patient which I'm going to see, this letter is going to go on my portfolio pathway application. So you then need to definitely sit and talk about all the details, and then you have to enter all of those in your letter, aiming that this is the evidence which I'm going to use for my portfolio pathway application. So very clear, structured letters along with safety netting advice, because your health promotion evidence, when I'm going to talk about, is quite about your clinic letters, because that is the evidence with what you talk about in your with your patients about health promotion and safety. Then communication with children and young people. Obviously, quite a few trusts are dealing with up to 16, and some of them, like in my trust, we look after children up to 18. So what I normally would be doing is any child who's above 12, I normally writing, instead of writing a letter to the GP, sometimes I do write the letter. If there is an issue with mainly communication with the child, I will address the child and write a letter to the child. and then copy that letter to the GP. And addressing in that way, you are directly communicating with the child. Similarly, you can use an evidence. For example, if you had a phone call from a mom and you had done something as an evidence, you've spoken to her, you have addressed some concerns from her, if you are on call registrar, and I would suggest you go back and document it. If you have your, like, for example, if it is on the computer system, you make it as an e-document and attach it there, and then save it for your portfolio, that you had your communication on phone with mother, and you, for example, if you were talking to her about viral V's plan and she has called you that after 4 hours now my child is needing more, and you've suggested them to come back. Or for example, if she said it was 6 hourly and I've gone to 4 hourly, whatever sort of examples, sort of communications. Then examples of multi-agency communication. We are dealing with quite a lot of different specialities in our role as a registrars when we are working as a registrar. So there will be quite a, like if you are attending any sort of strategy meetings, if you are attending any TAF meetings, if you have a chat with school for any reason, occupational, anything, that is an example. So you need to make sure how you collect that evidence and use it. And again, not only that evidence, then reflection after that, that you attended a strategy meeting, you can use it, that this was the link of that strategy meeting, email sent to you can be used, that, okay, fine, you had that invite, you use that invite and that link as an example and evidence. But eventually, what was the learning outcome after that strategy meeting is important. There is no point to attach 10 strategy meeting and there is nothing written afterwards, that what was the outcome after that. So reflection is again important. Then feedback from patients and feedback from colleagues is very important. And then adaptation of communication of different audience. Basically, that's why I've given you the example of talking to school, writing letters to support accommodation. Lots of things we are doing can be used as the evidence of communication. Talking about procedures, we had quite a few discussion about procedure in our earlier discussion. So basically your DOPS, you have mandatory and optional DOPS. Everyone should be aware that intubation is not a mandatory DOP, it's an optional, but you have 4 mandatory DOPS, which you definitely have to do. One of them is IO now, and most of the time, if you have not done IO, it does not mean that you cannot provide the evidence. You can do it in a simulation situation. Ask your supervisor to sign it for you, and then write a reflection about what sort of learning was after that. And the feedback of your supervisor is important about that simulation. Again, then after all these DOPs, if you make a skill log sort of book that you can, in the last 5 years, you make 3 columns. For example, 1 column is for the procedure, second column is the procedures done independently, and then the third column is supervise the junior colleague, and write all those procedures, cannulations, lumbar punctures, and all those things, at least to show a rough number, and then write a reflection on that as well. If you have done supervise someone, and then you need to write a reflection if someone was struggling, how you supported them is a good example. And then teaching and supervising procedures, reflection on difficult procedures, simulation training. Simulation training participation is very important. They are making quite a more emphasis about provide the evidence of simulation participation. And obviously, when we do these sort of procedures, we do document all of that. For example, if I've done a UVC, I'm going to go back and write down the time and how did we did, who was present, and everything about that. Lumbar puncture, we write that. That can be documented in the notes, and that can be used. If you have taken a consent of lumbar puncture, you can use that as well, that you are able to take the consent and then write a brief reflection of that consent taking as well. In management, again, the clinical letters. So I have talked about clinical letters in communication as well, and clinical letters here as well. So the clinical letter which you're going to use in communication is the letter where it's more emphasis about you communicating with the patient and showing your skills about your communication. In clinical letters, depending on management, you are going to show that what sort of patients you manage. And that should be across all the general pediatrics and community pediatrics. So you should make one folder of general pediatrics clinic letter, one folder of evidence of community pediatric clinic letters, so that they know that you have dealt with that. If you do not have a rotation to general community pediatrics, you don't have to worry about that. We are seeing quite a few patients in our general peds clinic as well, like looking after ADHD and ASD children. We are seeing them in our general peds clinic for a few other reasons as well. And I think quite a few trusts are seeing all these ADHD for repeating medication in their general peds. So you can use that as your community peds clinic letters as well. Then your clinical notes, where you have definitely shown a consultant level experience of documentation in your notes, that can be used. And again, I would recommend you to divide it into two documents. One document is showing your acute pediatrics, and the second one should be about your neonatal management. And then your ED or resus scenarios and acute decision makings should be there as well. Safe prescribing example is you can cross-link here, but you can use it in another domain. Then all your MDT managements and discussions, reflection on showing your risk assessment, that should be used. Multi-agency meetings, chronic disease managements, any joint clinics, shared decision makings, and then again, reflection on all of that. HLLO 5, this is basically one of the HLLOs which we normally struggle. And it's not only us, even the trainees do struggle with this HLLO. It is only 5% of the evidence, but still we do struggle. If you are starting now, you still have enough time to think about. If you're seeing someone for any other reason, but there are a few things which can come on your health promotion, then you should try a brief time and address on that, and then use it for your portfolio pathway. For example, a patient you are seeing for some other reason, but has got, for example, asthma with obesity, diabetes with obesity. So you can use like this weight management and all that stuff, lifestyle modification. Someone coming to your clinic with sleep, behavior problems, and all those things, you can use that as well. I've given my example of diabetes because I'm one of the diabetes consultants. So I deal with quite a lot of difficult teenagers with diabetes, and talking about their issues about driving with diabetes, alcohol with diabetes, epilepsy children with their driving, medications, all those things can be used as an evidence of health promotion. Talking to patient and family regarding health promotion material, for example, if it's obesity, then talking about not only the child as a whole family, about working as a whole family together, and if you have a documentary evidence for that. Talking to school about quite a few things, promoting the health promotion, public health reflections, CBDs on health promotion. And if you go on our CPCH website, there are lots of e-learnings which you can use for the health promotion. Leadership and management, again, there is a bit of struggle on this. And I must say, try to find, and in NHS, there are lots of ways you can prove yourself as a leader, and always make sure leader not as a clinical leader, they are talking about leader as in general, with quite a few other things as well. So you have to provide evidence for other things. So you can divide it into clinical side and non-clinical side as well. So for example, rota coordination, dealing with induction of the junior doctors, medical student lead, physician associate lead, BMA representation, SCS tutor, anything like that, IMG mentor, quite a few things, leading QI projects, working with risk management team. So there are quite a few things which you can use as a leadership roles. So try to find all of those things. And then again, talking about leadership in clinical sense is that you have to provide evidence that you are a leader and you are working as a consultant level in your clinical role. Talking about HLLO 7, basically this is mainly about patient safety and safe prescribing. We only need 5% of evidence, but still sometimes we do struggle with that. First of all, we need to read thoroughly what actually we need, and then go for that. There are quite a few sort of CBDs and e-learnings about safe prescribing, which you can use. They are on Royal College website as well, and there are NHS England website as well, which you can use successfully. Then involving in any incident, writing the reflection on that as well, and then basically contributing in your departmental risk management meetings, safeguardings, and if you are being investigator for an incident, that can be used as well. And if you are chairing those sort of meetings where risk management and these things are discussed, you can then use that evidence primary here, and then you can cross-link it for your HLLO6 as a leadership. And also about any involvement in the clinical governance issues. Then again, the HLLO8 is basically quality improvement. So you definitely need to have a closed loop audit, at least minimum of one, with basically measurable improvement, showing that you have made some changes. How you are going to present that is you need to, not only the certificate of an audit is important, you need to present your audit report, your presentation in the governance meeting. So you should show your attendance, and then in the governance minutes of those meetings, it's been documented that you were there and you have presented. Then your presentation is the next thing to be attached. Third thing is your certificate of that audit. Fourth thing is your reflection about that audit. And even in that reflection, if you have mentioned that you have made some changes and you would like to re-audit after some time to see the changes and how you are going to make that happen, that you are going to do some, for example, I can give you an example. For example, if you're doing a QI project on burst therapy in the viral V's child, and you think that that burst therapy is not being done properly, you have done a QI project and you have picked few things. Now you need to work on it. For example, you go and teach ED doctors, you teach your own pediatric colleagues, and then you re-audit after some time and then write down a reflection that you've made some changes and you're going to re-audit at certain period of time. You are showing your evidence that you're interested about finishing it as a closed loop audit afterwards. But at least still one closed loop audit is mandatory. Then talking about safeguarding, yes, level 3 safeguarding certificate is important. And as there was a discussion about the Royal College safeguarding, I would say even that's not mandatory, but that is helpful because you attend those courses, you learn a lot of things. If you don't want to spend that money and you have still got the membership and you are on Kaizen, you do have access on the website of the Royal College, and there is a thing called Child Protection Portal. If you go to Child Protection Portal, you will find quite a few interesting sort of things there, and then you can read that and you can write a reflection that, and you can use the link of that child protection portal, that, and you can attach that, copy paste that link in your reflection that I've read this and then I've had this sort of learning. For example, bruising child, you can write that I've seen a child with bruising in the clinic, even if you have not written a safeguarding medical report, but then you have gone to read the child protection page about how to manage a child with bruising, and then written a reflection that can be used. But it does not mean that you should not be having the evidence of medical reports. The medical report still is very important. You should have medical reports, child protection medical reports written for the last 5 years. And for that, child protection portal is important, but then it is good to attend the safeguarding and medical report writing course on the Royal College website. So you find that sort of courses. There are like digital, I think safeguarding digital world or something like that. That is a good course as well. So there are statement and report writing courses and evidence and writing reports for the court. All those things, if you are lucky enough that you never had to go to that, you can use that as an evidence that you have done those courses and written a reflection on that. So you're proving that even if you had not come across that, you've provided that evidence. And I must say, if you have not done that and one of your colleague has done that, you can sit with them, have a discussion. You can write a reflection that you helped your colleague to write a report, and this is your reflection on that. Then again, if you had your community peds rotation, and even if not, there are some looked after children clinics. If you can ask your department that they can allow you to attend like couple of those, and then you can, on the Royal College website, there is a nice document about looked after children. You read that document, attend those clinic, and come back and write a reflection on that. That is a good learning. All your peer review meetings, MDT meetings, any clinical correspondence regarding safeguarding. There, and if you don't have your Kaizen, then still our CPCH has got safeguarding case-based discussion document. You can do a safeguarding CBD on that. You can use your the maps which you use on your child protection medical. You can use those, that you can provide evidence that you know how to use that map and how you document all of those things. You're teaching to your junior colleague about child protection and safeguarding issues, and your own work-based assessments and work-based assessments for others is a good evidence. Talking about teaching and education and training. So one thing I would like to mention, Train the Trainer course is a must course. So you should have that. Anyone who wants to do the portfolio pathway, when they are towards their end, like last 2 years of submission of their application, that is the right time to do the Train the Trainer course. Then educational supervision course is available on the Royal College website. That is something which is useful, so that you can provide the evidence that you are now working almost a consultant level and you are supervising others. Teaching the junior doctors, providing the evidence about that. Then your teaching presentations, you build a habit of getting the feedback. So your presentations, and I know most of us are doing quite a lot of teachings, and you should not be attaching all those. Like in 5 years, if you have done 30 presentations, you don't have to do all 30. Good quality 4 or 5 presentations are enough, with the feedback afterwards, and then writing your reflection after that, that I had that feedback and next time I'm going to change my practice. Because, for example, you've done a presentation and someone has given you feedback that it should have been more interactive, then you can write a reflection that I'm planning to do this session again, and I'm going to add few scenarios, and I'm going to involve more audience. So that is a good evidence that you have made your things better after that. Supervising junior colleagues, again, in their teaching, and then providing evidence. If you're filling their Kaizen, that's good. We have few GP trainees who come there. Some of them are using Horace, some of them are using other portfolios. When you fill their assessments, sometimes when you click submit, it's gone and you don't have any evidence. What I used to do was, before clicking the submit, if you use Control P button, it's going to say print, and you go and instead of printing, save it as PDF for yourself, obviously with the consent of the person who you are doing, and you can tell them that this is what you're going to use for your own portfolio. And then you only have to do is anonymize their name, so that if you are providing assessment for someone, you should not be using their name in their assessment, because sometimes when we write their name in their assessment. So make sure you have anonymized that. Then research is again slightly tricky domain, because previously when people were doing Caesar, it was quite a few sort of things. People were thinking, I don't have any publication. What's my point to go for the Caesar, because I cannot do it. So that's not right. If you have a publication, very good. If you don't have it, still there are lots of ways to prove that you are involved in research and evidence-based practice. So if you are involved in any sort of things where someone is going to make some changes, for example, developing a guidelines. If you go on your trust website and see that any of the guidelines is about to expire, and see who's the owner of that guideline, discuss with the consultant who has written those guidelines, and you can offer them, I'm happy to help to update these guidelines. Go and read those guidelines. With their support, change those guidelines. That guideline is an evidence base, and you have changed those guidelines. Read the articles which are new, and then present in your journal club and write a reflection on that. For example, during COVID, there were lots of new articles coming up on vaccines and all. I've used that, and it was very useful for me. Anything new coming, I was reading those articles, doing my presentations, and then writing a reflection about that was very helpful. And if you are good at critical appraisal, then you should do some teaching about that as well. If you have done any poster presentation in conference, that is something we can use. Then if you have read any article, but you have not done it as a journal club, still you can use the link of that article in your reflection, that this is the link of that article which I've read, and this is my reflection that I'm going to change my practice after reading this article. You don't have to attach that article in your portfolio. It's going to increase the number of pages. Just copy paste the link of that article, and that is enough. And then I think that's all. You just need to decide, my evidence is strong or my evidence is weak, and if it is weak, how I'm going to make it strong. So strong evidence is basically a consultant level of an evidence. Just attending a course is not enough. We are doing those for the part of our appraisal, but that does not mean it's a strong evidence. Attending a course, writing a reflection, and then teaching others what you have learned from that is going to be more stronger. Independent clinic letters, completing the guidelines, closed loop, I've given a few examples of those. But then attending MDT only and showing your attendance in MDT is not a good evidence. If you have attended an MDT and in MDT minutes, there is a discussion that this person has said this, and we are going to make some changes, it's your participation. That is a more strong evidence. That's all. And I will take questions and I'll try to work on my basically desktop. It's not, my computer is hanged, so I'm going to work on the desktop and see if I can show you my evidence.
Okay. Thank you very much indeed, Sadia. That is absolutely amazing, amazing presentation. Thank you, Nabiha, as well. Both of your presentations have really set the scene, especially for those who are thinking about starting the application and those who have already started the application, actually. There are a few questions.
I am able to share, so let's quickly show a rough sort of.
Good.
And are you able to see my desktop now?
Yeah.
So basically, these are my 11 folders. So all of you, I would suggest to make these 11 folders. And then whenever you are on your ward, what I used to do was, at the end of my week, I used to sit, I had a small diary. I'm still an old school sort of person. I write things. So I used to write everything in my small diary. And at the end of the week, I used to look through it, that what are the things which can go into which HLLO. And I used to put everything in the relevant document. And then in your folder, you can make subfolders. For example, this is my HLLO one, which is professional values and behaviors, all the appraisals, all your CPD certificates. I have done because I've got quite a few subspecialties. So I've done it as per specialty: nephrology, neurology, diabetes, acute pediatrics, all those. And then reflection. You would see reflection was my mandatory folder in all my HLLOs. So put everything in the relevant subfolder. Similarly, your second domain is your communication. So correspondence with health professionals, correspondence with patients, correspondence with other colleagues, your discharge summaries, your referral letters, handover documentation, your CPTs relevant to communication, reflections on communication. If you're using Kaizen, there's discussion of correspondence that you can ask any of your colleague to look through your clinic letter and write their opinion about your letters, your colleague feedback, your MSFs, your patient feedback, and the feedback you've done for your colleague. Then talking about your procedures. So all your resuscitation courses, which are mandatory, all your mandatory DOPS, your optional DOPS, then DOPS done for colleagues, your skill logbook, feedback from the colleagues about your procedure skills, your case notes about your procedures, and your reflections. Then your management, which is a big domain. So clinic letters, and again, because of my quite a few relevant subspecialties, nephrology letters, diabetes, general peds letters, community peds letters, mortality meetings, MDTs, ACATs, case-based discussions, mini CACs, general pediatric notes, leaders case-based discussion, neonatal case notes, and then reflections. Then again, your CPD is relevant to health promotion, developmental law, clinical logs about clinical letters about health promotion and reflections on health promotions. Then CPD is relevant to your leadership. So leadership and management is again one of the mandatory courses. BMA representative role as a leader, chairing different meetings, Royal College role of RCPCH represented, SS tutor role evidence, induction of the junior doctors, and these are my miscellaneous other leadership roles, and then reflection on my leaderships. Then again, this is patient safety, all the patient safety relevant CPDs, reflections, and evidence involved in any incidents, risks. That is one document. Again, QI projects, all the audits, along with their presentations, reflections, and certificates. All the CPD certificates about learning how to do the audits and audit focus meetings. So all my reflections are along with my audit presentations. Then education and teaching presentations with feedback and their reflections. Then evidence of involving in teaching. There are lots of feedback from people and invitation of different teachings. So I haven't attached all my presentations here, but I've got the evidence like roughly how many presentations I've done in last 5 years as an evidence of invitation of different teaching courses. CPD certificate is relevant to my teaching experience, which is including my simulation-based teaching as well. And then work-based assessments done for the junior colleagues. And then last but not the least is your basically reflection research domain. So journal clubs, updating the guidelines, all the courses relevant to research, reflections on your research. And this is like I have taught few things about research thing, how to write an abstract and few different other things about your teaching evidence, about your research. That's all.
Great. Thank you. Thank you very much. So in the interest of time, can I suggest that if at all possible, we reply to the questions if it can be brief. So we'll take the first one, question regarding ward round documents. What is quality? We see majority of sepsis and bronchies, etc. What is quality in ward round documents?
So I would say they would like to see your experience in the last 5 years as a general pediatrics as a whole. So I would not be submitting like 10 bronchiolitis and sepsis children. So I would, in the last 5 years, we would have been seeing quite a few other cases as well. So if you write down roughly your main cases which you have been seeing, and then provide evidence as a variety rather than using 10 different similar viral Vs and bronchiolitis children.
Thank you. And for beginners, how do we start collecting evidence on a day-to-day basis? For example, for board round notes, how do we get evidence if the system is paper-based?
So if the system is paper-based, what I would suggest you to do is obviously you have to then make 2 separate folders. One is the folder when you have got your real patient notes, because when your verifier is going to sign those documents, they would like to know the details of the patient to verify that this is right. So you should have a notebook where you have got the patient NHS or hospital number. And then you can ask your, if you have a ward manager or someone, that I would like to have these notes, and take permission, and then use those notes, scan them, and obviously do a redaction and before you save it for yourself. But in your paper diary, you should have that patient's hospital number with you, so that when you go to your verifier, that this is what I've redacted, but this is the hospital number, that if they want to verify and have a look on the system before they verify your document, then you know that this is the hospital number. But for the sake of confidentiality, you should redact it and save it for yourself. But you should have a spreadsheet where you have got the details of the patient for your verifier.
Thank you. And someone joined late and they wanted to ask where to access the documents to start off with.
Sorry, I couldn't understand.
Where to access documents to start off with. And I think, Nabiha, you have shared lots of relevant websites, including RCPCH curriculum, pediatric syllabus, pediatric specialty, specific guidance, etc. So that's all very helpful.
I mean, where to start documents, if you're asking about where to upload the documents, you can, like we've just talked about through the morning, it could be either the Kaizen portfolio, your own portfolio, if you've got paper documents, just like how you see Dr. Sadia has made her folders. That's quite a nice and tidy way of doing it. And I don't see any other way, I'll be honest, that you can actually work on this volume of evidence. You've got to have that structured approach and those folders,
Yeah.
if that answers your question.
Thank you. And would advice in discharge letter be counted as communication with families if advice to patients or parents?
If you had some advice that is going to be used as communication to family, but that is your written communication, they would still like to see your verbal communication. So you can use a reflection to show your verbal communication. For example, a difficult conversation with a child or a parent, you can write a reflection, because obviously it's difficult to show your verbal communication through your written communication.
Thank you. And what about discussion with other specialties? Where can we input that evidence?
So if it is your referral letters or emails, both can come under HLLO3, which is your communication. So you can use it as a folder of a document folder of communication with relevant specialties, but you shouldn't be doing per document every specialty. You can use it as a generic. So your occupational health referral, speech and language referral, anything, all of those discussions can come under the same. Even if it is an email communication, you can use that as a communication with the colleagues.
Thank you. And Hina is asking if we are following patients in late effects clinic, can that be a part of community pediatric clinic experience?
Sorry, I couldn't get the question. Anyone else can answer? I don't know what does that mean.
Yes, likewise. That's why I wasn't able to answer, because I didn't quite understand what is the late effect clinic.
Yeah.
Hina, if you could explain a little bit more what sort of a clinic that is.
Yeah.
Can I speak up if that's all right? This is interest of time, so sorry. Yeah, basically we have like late effects follow-up clinics for patients who have completed their treatment in oncology, but it's more like a general follow-up, in the general health and everything. So all this a late effects clinic. So could that be, if we put a reflection on it, because we've seen the patient in a holistic way, could that be counted as an evidence for a health promotion and like in terms of community pediatric, because obviously if I haven't rotated in community pediatrics here in UK, can that be counted as if I've given a reflection on it and if I've actually seen the patient holistically and not just from an oncology perspective?
Yeah, I'm not sure why not. I do agree that you should be able to, if you have addressed vaccinations, breastfeeding, these are the health promotion things that you need to talk about, for example. Yes. I'll just take the liberty for 1 second, Dr. Masur. I'm sorry to interrupt, but I'm just going to share my screen if that's okay. And I'll just want, the document I have put in there for your syllabus. This is in the chat, okay? So this is the RCPCH syllabus document. And let's look at the communication outcome. So they give you these capabilities, which are almost examples of what you can use, exactly what Dr. Sadis talked about. So, effectively communicates in MDT, models and teaches, active listening skills, demonstrate to others how to manage effective consultation. So this is a really valuable document which should help you. Then they've got illustrations here. 14-year-old girl with chronic fatigue syndrome, 2-year-old boy with spinal muscular atrophy, trainees joined by a medical student in the clinic. What are the things that you will do? Okay, so go through, before you start your application, try and go through this, which will give you lots of examples to use in the application. It is a really good document.
Yeah, that's what I was talking about, that you can use those as to start with and then use your own sort of
course, yeah.
Yeah.
Sure. Nabia, you have replied regarding revalidation, which is not due till 2028, but somebody wants to submit the application before that.
So it doesn't matter if you're not been revalidated, as long as you have your 5-year appraisal, that's absolutely fine. You must have had a revalidation prior to that. Revalidation is not a must.
Yeah, because some people might not have been in UK for the last 5 years. If they are less than 5 years, you don't have, it's not mandatory for you.
That's amazing, and lots of praises for the presentations, and bundle of thanks from different participants. So really grateful to both of you, Nabiha and Sadia, for amazing presentation. I've got a couple of slides to share before we close. Right, can you see my slide?
Yes.
Okay, so very quickly, some do's and don'ts of portfolio pathway application. If you have made up your mind, please start early. And what the assessors are trying to do is for you to demonstrate senior level thinking, really, sort of consultant level thinking. Try and be organized and structured, as we discussed. How do we create folders and subfolders? And you need to map the evidence to the curriculum and HLLOs, as we have already discussed. Don't just submit the evidence, not about the submitting the evidence. It's about submitting the evidence with some learning, with some reflection. But what is it that helps you, or you gain some experience, some knowledge, you had some learning, and how would you change it in future, or how did you make the change in future? So quality, not quantity, but then you need to have some quantity, but you need to give evidence in terms of quality, really. When you are almost reaching your submission stage, then get someone to review your application, somebody experienced in portfolio pathway process. Find a buddy, find a colleague who is going through the same, and motivate each other. Do a joint evidence collection. I think learning from each other helps tremendously. And as we discuss, evidence to be from the last 5 years. And don't assume, and there are some don't assume that assessors will figure out by magic if you have not explained the things explicitly. So help the assessors, please. Don't give up. Once you have started, hopefully you can do it. As he said, set aside set amount of time every day, or maybe every week, or whatever, and keep working for it. Don't overload with irrelevant, rubbish documents. You're just wasting everybody's time, including your own time. And reflections have to be specific. What did you improve? It improved my skills. That doesn't help. But if you say it improved my communication skills with a teenager who was not communicating with me, or who was not open about personal issues, etc., that helps. And we've already talked about formatting and presentations. In our next sessions, we'll be talking about redacting. So that's very important. It has to be anonymized submission, and what is to be anonymized and what is not required to be anonymized, we'll talk about it in our future parts of portfolio pathway webinars. And we've already discussed this uncertified or informal evidence that's not useful at all. If there are gaps, then explain that. And we've already talked about creating a link with GMC and creating your application with GMC. But then we talked about as to the fact that there is a deadline, isn't it? And so therefore, only open up your application with GMC when it's the right time, and aim for submission before the deadline, really, rather than leaving it to the last date. So I think we are coming to the end of our webinar. Remember that look at pediatric curriculum and syllabus. Look for the evidence that support your application before applying, whether this is RCPCH or GMC. Remember that GMC website, do not download the guidance, but keep looking at the guidance because it keeps changing. Cover all 11 HLLOs. We have already discussed. Please don't try and upload more than 150 documents. We'll talk about referees and verifiers in our future sessions, but remember there is help available, both from RCBCH as well as from GMC, that can guide you through the application process as well. So thank you all very much for attending this webinar. Finally, your feedback is absolutely essential in help us shape the future webinars and make improvements to the webinars. Please look forward to the date of our part 2 of Portfolio Pathway webinars. That will be sometimes in June 2026. So on behalf of UKIPPO, I'm really grateful for your participation and attendance, and hope you have a great weekend ahead. Thank you very much. Assalamu alaikum.
Walaikum salam. Thank you, Dr. Mansoor.
Thank you, Dr. Mansoor.
We can stop recording now.